my link, so her name is me, but I guess that's all right. Should I ask her to change it?
Yeah.
Okay, Maya.
I think we're live now. So if you just
I'll just rename. Okay, that's fine.
Right. Hi guys, thank you so much for joining us on this tutorial. So today's tutorial is on hearing loss and audiograms given by Nishita. Just a few rules. For those of you that are watching via Zoom, if you've got any questions or comments that are covered in the moment, if you just want to pop it into the chat, and any questions that can wait to the end, if you just want to pop it into the Q&A. If you're watching on the Facebook Live, just comment your questions and comments, and I'll just pass them on to the tutor. And that's all from me now, so I'll pass it over to Nishita. Thank you.
Thank you, Bridget. Thank you for that lovely introduction. So yes, hi guys, my name is Nishita, and I'm going to give you a tutorial on hearing loss and interpreting audiograms. So just a disclaimer, so we do this at the start of every tutorial. All of these are my own, and it's just for educational and informational purposes, not for any official medical conditions or advice. So learning objectives. So what we're going to cover today is we're going to try to understand the anatomy of the auditory system and the physiology of hearing, to understand what hearing loss is and the impact it can have, to understand screening tests and investigations used to test for hearing loss. So this includes Weber's test, Rinne's test, audiograms, and we're going to cover Tympanograms as well a little bit. And to know key conditions that cause hearing loss. There's quite a lot, but we'll cover a few of the key conditions that you need to know, and that will include going through their presenting signs and symptoms, appropriate investigations, differential diagnosis, and treatment too. And also to be aware of the UK management guidelines for hearing loss, and to roughly be aware of the ENT technology that we can use for the management of hearing loss as well. So a little bit about me. So as I said, I'm Nishita. I'm a third year medical student at Audiograms University. So that's a fairly new medical school in Essex. So why am I teaching you right now? Because the Becoming a Doctor tutorial series is really great, and I've really enjoyed all of the tutorials so far. And I do quite enjoy teaching, and I like ENT. So just another disclaimer, I'm not an ENT expert, I'm just a third year medical student, but I do I have an interest in it, so I have been doing reading, and all of the information in these slides today are from credible sources that are referenced at the end, and so forth. And obviously, if you guys have any questions or even any contributions or thoughts, or if you think that I could say something differently or you have anything else to add, please do put them on the chat, or you can ask them at the end as well. It's up to you. So I will be trying to look at the chat function throughout, but if you add anything to the question and answer box, then I will look at it at the end of the presentation. Okay, so anatomy and physiology. So before we go into like the clinical cases and stuff, I think it's really important to understand the anatomy and physiology. So we'll quickly do a recap of the auditory system, so you understand what's going on. Okay, so just a little bit of an overview. I'm just going to get my chat function up so I can see. Okay, cool. So just a little bit of an overview. This is the ear. I'm sure all of you know that. But what you usually see when you see a person's ear is just the just this bit, which is called the pinna or the auricle as well. And the ear is split into three parts. So you have the outer ear up to the tympanic membrane. Then you have the middle ear, which is from the tympanic membrane up to the stapes. We'll go into a little bit more detail in a minute. And then you have the inner ear as well, which is the cochlea, and it also includes the balance system as well, like the vestibule, but that's outside the scope of this presentation. We're just concerned about the parts involved in hearing, but there is also the vestibule and the semicircular canals as well. Okay, so outer ear. So I've got a picture here of sound waves. I'm sorry if this gives you flashbacks of GCSE or A-level physics, but we can't do hearing loss without going through sound first. But there's not much I'm going to say, but it's just so you can hear because of sound waves, and when there's a noise, you have sound waves like this. So for example, A here is normal air, and when you have B, which is sound, there's like vibrations. So there's vibrations of the particles, and that's key. That's what sound essentially is, and that's why, for example, in space where it's a vacuum, there's no particles, you can't really hear sound. But yeah, that's all I'm going to say about this. But how the ear works is essentially sort of like a funnel. So this funnel, I've just inverted it, but it gets all of the sound, and then the pinna and the auricle, which is this bit that you see, that concentrates or like funnels the sound into the external canal. Or the external auditory canal, and then that sound travels and it hits the eardrum, or what is also called the tympanic membrane, and that's the outer ear up to there. So then we move on. So when it hits the eardrum or the tympanic membrane, that tympanic membrane vibrates. And then we get, so here's just a little view of the tympanic membrane. So this is what you could see if you look through an otoscope. So, or what you should see, sometimes it's quite hard to handle, but what you should see is something like this if it's a healthy tympanic membrane. So key things to kind of take notice is here, there's the cone of light. So you'll see like a reflection of the light from the otoscope. But if there's something in the middle ear, which we'll come to in a minute, you probably won't see this, or the light will be quite dull, like the reflection. There's also the short process of the malleus, which is the bone behind the tympanic membrane, and you'd see that there. There's also quite a lot of other parts, but I won't go into that today just for time's sake. Then you have the middle ear. So the main parts of the middle ear that we're going to cover today are the ossicles. So these are the malleus, incus, and stapes. So what happens is that you have the ossicles, and once the sound wave hits the tympanic membrane and that vibrates, the ossicles move backwards and forwards. And what's really important is that they amplify the sound. So it's said that they can do this about 18-fold. So they can amplify it 18 times. And that's why it's really, really important. And they kind of compensate for sometimes like sound and air like lost, like the vibrations lost while they move through the all the way through to that area. And so I've just put, you might be wondering why I've put this, but sometimes people refer to it as the hammer, anvil, and stirrup, just because they kind of look like these objects. So like that'll be like the malleus, incus, and stapes. So they kind of look like that a little bit. And then the stapes, and then you'll go into the inner ear, and the stapes joins to the oval window of the cochlea, which we'll come to in a bit. And the stapes, the movement of the stapes moves the oval window. Okay, so I also wanted to kind of touch on this, which is really important in a bit when we interpret the audiograms. So normally what we just talked about is air conduction, but sometimes if something in this pathway is blocked, so for example, if there's earwax, or if there's something in the middle ear, or there's a problem with the ossicles, so say there's no incus and the malleus can't vibrate it. So if this pathway, there's something wrong with it, or it's blocked and sound can't travel, then what happens is sort of bone conduction takes over. So air conduction is lost, and bone conduction is what's primarily there, and the sound travels. Sorry, the picture is not very, very clear, but the sound travels through the temporal bone. And it travels via conduction to the cochlea directly, which is the inner ear, and then that's how sound is heard. So this normal air conduction and amplification of the sound doesn't happen. What's important to know is that air conduction is like the louder louder aspect because, so, sorry, there's questions in the chat, I'll get to that in a bit. Okay, so you said, can you explain why bone conduction takes over? I can't quite understand. Okay, so what I mean is, so you have, okay, so you have air conduction and bone conduction usually, okay? So you have this, so sound travels through here, and so you have sound waves here, and once it hits the tympanic membrane, then you have a movement of the tympanic membrane, and you have movement of the ossicles. Yes, so that happens. But if this is blocked, say the tympanic membrane is ruptured, for example, or there's something, there's fluid in the middle ear, then that vibration doesn't happen. These ossicles can't move. So then that signal, that sound signal, is not hitting the cochlea anymore. So you essentially won't be able to hear. But people can still hear because of bone conduction. And if you remember from GCSE physics or so forth, air can travel via different mediums of matter, so they can travel through air, but they can also travel through bone. So so when sound is funneled through here, some of the sound also hits your head, your skull, and the temporal bone. So that's why particles conduct, so the sound is conducted through there via the bone, not through the ear canal, via the bone, and then it hits the cochlea, so your air conduction is not happening. So what I mean by that is your air conduction isn't happening, so only your bone conduction happens. Does that clear it up? Do let me know if that clears it up, but if you want further clarification, I can try to explain. Yes, thank you. Okay, great. So yes. And there was also another question, does a cone of light tell you what eardrum this is, i.e. if it's on the right, it's the right ear? I think I heard that once. Yeah, I guess you could say that as well. It could, because if you think about this, it's not very symmetrical, is it? So so correct. So it could essentially tell you if it's the right ear or the left ear. Yeah. Okay, so now we'll go into the inner ear. So we said that the stapes, it hits the oval window, and then once that moves hits the oval window, there's liquid inside the cochlea. So there's perilymph, and then there's also endolymph, and that depends where it is. So you've got the vestibular canal here, you have the tympanic canal here, and then you also have the cochlear duct. So the oval window is here. So just imagine, so this is like a cross section of this area, say, and then the oval window, it hits, it's here, and then once the oval window is moved, then the liquid here, so the perilymph, it moves as well. So once the perilymph moves, so that the movement goes towards the center of the cochlea, which is here, and that's called the heliotrope. And then the movement also hits the endolymph. So this membrane here, it can move. So when there's movement in the perilymph, there's also movement in the endolymph. And when there's movement in the endolymph in the cochlear duct, it affects the organ of Corti. So this is called the organ of Corti, and it's like the organ of hearing. And then there's like little hairs there. Sorry, I should have put a detailed picture of that, but there's like little hairs there. And then when that liquid in the, so the endolymph moves, then it moves the hairs. And then when there's movement of the hairs, then if you think back to your preclinical days, so when there's movement of the hairs, and it causes movement of electrons, and this causes depolarization. So there'll be like action potentials, and those action potentials, that's called transduction. So you've got sound turning into signals like action potentials, and that goes via this nerve into your brain. Does anyone know what this nerve is? I think it's on one of the diagrams, but anyone know what the nerve is at all? Okay, I'll tell you. So, so this is it says vestibular nerve here, but that's the vestibular nerve from the vestibule. But there's also here, this nerve is the cochlear nerve. So they join together to form the vestibular cochlear nerve, which is cranial nerve 8, and then they go to the brain so you can hear. So here we've just got just briefly about the CNS. So obviously it goes through the vestibulocochlear nerve, and then it reaches different parts of the CNS. So I won't go into too much detail, but then the vestibulocochlear nerve hits the cochlear nucleus, and then you get to the inferior colliculus, and then eventually to the thalamus here. And what's really important here is there's coordination of other senses as well. So from the thalamus, so once you hear something, you know what to say because the thalamus kind of coordinates that. And then after it goes into the primary auditory cortex, which is here. But yeah, so there's more detail on the slides, so you'll get the slides, but you can read the notes underneath later. But just for time, I will move on. Okay. Oh, and we had some questions. Oh yeah, cochlear nerve. That was correct. Well done. And you also said, is the hair in the organ of Corti? So yeah. It's there. That's where all the transduction happens. So here is a question. I will put a poll up, and you can answer. So yeah, read the question. So I'll read it out for you. So a patient complains of loss of hearing in the right ear. Examination reveals otosclerosis of the foot plate of the stapes to the surrounding bone. Which part of the bony labyrinth is involved? Okay, I'll give you a couple more seconds. Okay, perfect. I am going to end the poll now. Okay, so we had quite a range of answers. So thankfully the majority of you said oval window, which is correct, but I'll go through why the others aren't right. So the question was, a patient complains of hearing loss in the right ear. Examination reveals otosclerosis of the foot plate. Examination reveals otosclerosis of the foot plate of the stapes to the surrounding bone. So which part of the bony labyrinth is involved? So some of you put incus. So incus is actually an ossicle. So I was kind of trying to trick you there. So maybe the incus gets otosclerosis as well if it spreads from the stapes to the incus, but actually the incus is not part of the bony labyrinth. So the bony labyrinth, so to be clear, so that's where the cochlea is. So that's the bony labyrinth. So what is a part of the bony labyrinth? The temporal bone is too general. So the temporal bone is like all of the bone here, and it's not specific enough for this question, and it's not a part of the bony labyrinth. In fact, the bony labyrinth is in a cavity in the temporal bone. So it's not the incus, and it's not the round window, because I'll show you the diagram again in a minute. So no one put the cochlear duct, which is good, but it was out of, so now we'll just talk about why it's not the round window, and that's because, I'll go back. So if you see here, the stapes, it joins to the oval window and not the round window. But the round window, what it does is, there's a lot of vibration here, so it's just to kind of that vibration can kind of sort of exit from via the round window, and then you also have your eustachian tube here, which I didn't mention, but I'll mention now, and that joins from your ear to your nasopharynx. So it's a connection from your middle ear to the nasopharynx. But yeah, that's why it's not the round window. But yeah, well done. Okay, so now we'll talk about hearing loss. So what exactly hearing loss is, and also the impact it can have. Okay, so firstly, what even is hearing loss? Okay, so I'll just quickly turn the light on. So I don't know if you can see me. Okay, so what even is hearing loss? So obviously this might be quite obvious, but a hearing loss is, a definition is a person who is not able to hear as well as someone with normal hearing. So we have a threshold for hearing. So we'll go through this diagram again when in a bit when we go through how to interpret audiograms. But so this is loudness, so it's a measure of loudness, and we use decibels as a measure of loudness. So so this is 20, but the WHO definition is 25. So it's around 20 to 25. Anyone that can hear above 20 to 25 has normal hearing, but if someone is not able to hear as well as someone with normal hearing, is unable to hear as well as someone with normal hearing, then they are said to have hearing loss or a hearing impairment. And it's also split into mild, moderate, severe, or profound, depending on what degree of like loudness of sound or like the decibels that you can hear. And disabling hearing loss is not in this diagram, but a term disabling hearing loss is used, and that is if in the better hearing ear, so the ear that you hear the best with, there is hearing loss of over 40 decibels in adults or over 30 decibels in children. So it's like there. So that would be disabling hearing loss if that's in the better ear, and the worse ear has even severe hearing loss. I hope that makes sense. But yeah, there's another question. Should we know about the scalar tympani and the vestibule in the cochlea? So perhaps just be aware, but so you'll have a lot of clinical questions. So it depends on your medical school as well. So I can't really say if you personally need to know about it, but definitely be aware of it. So whenever I like to learn about something, any medical disease or something, I feel like I am more engaged when I look at cases and also the impact that it can have. So I'll quickly go through like individual impact of hearing loss. So obviously, as all of you can imagine, communication with others is affected. There's spoken language development delay in children. So if you have congenital hearing loss and the child is prelingually deaf, which means before they can speak or they have never heard before, and they're deaf, then it's hard for them to learn. So because when you learn languages, you hear and then you speak, but as you can imagine, that's affected. And this can affect academic performance in children too. It might cause exclusion from community. It can cause loneliness, isolation, frustration, and there's so much more as well. So it's important to consider that when you treat a patient, you have to think of like the holistic approach to medicine. Okay, so also the global impact. So we have some big numbers here. All of these are from the World Health Organization. So 466 million people worldwide have disabling hearing loss, and 34 million are children. 60% is actually of childhood hearing loss is actually due to preventable causes. 1.1 billion young people. So when we say young people, we mean 12 to 25. Are at risk of hearing loss due to exposure to noise in recreational settings. Unaddressed hearing loss poses an annual global cost of $750 billion, and interventions to prevent, identify and address hearing loss are cost effective, and it can actually bring a great deal of benefit to the individual. Over a third of the people over 65 do suffer from disabling hearing loss, and these areas of the world are where there is the greatest prevalence. So Benedict has said, scalar tympani carries sound vibrations from the oval window. Vibrations exit the inner ear via the scalar vestibule to the round window. Yeah, that's what was mentioned, but thank you. Okay. So there's three types of hearing loss. So Yeah, so as you guys might have heard, there's conductive and sensory neural hearing loss. So conductive hearing loss is when the outer ear or the middle ear is affected, and that conduction of air, or sorry, the conduction of sound is affected. But you also have sensory neural hearing loss when it's the cochlea or the nerves beyond that. When it's that's affected, that's sensory neural, because that's to do with like sort of the nervous system and the senses, the sensory neural. But here it's conduction. So the problem with the sound conduction is an issue. And there's also mixed hearing loss as well, when you have elements of both of conductive and sensory neural hearing loss. Okay. So here's just another diagram about that. For example, so does anyone know of any causes of conductive hearing loss? Feel free to write in the chat. Yeah, exactly. Otosclerosis is definitely a cause of conductive hearing loss. Presbycusis. So presbycusis, it can be sensory neural too. So it is mostly usually sensory neural presbycusis, but we'll go through that in a minute. Otitis media is definitely a cause of sensory neural hearing loss. So yeah, those are good suggestions. So those are good answers. We will go through all of them actually later down in this presentation. So diagnostic tests. So to understand screening tests and investigations used to test for hearing loss, so you have the Weber's test, the Rinne Test, Audiograms, and Tympanograms. So we'll go through those. Okay, so first we have the Weber's test. So I didn't actually include any videos in here because I wasn't sure about the tech with that, but I do have pictures. So this is a tuning fork. So just imagine someone's hit the tuning fork and it's vibrating at the moment, and you put it here on the center of the head, and then as you can imagine, the sound vibrates. So here it's sort of testing conduction. So as we mentioned conductive sound conduction, not air conduction, but bone conduction. So as you can imagine, that sound is conducting through the bone, and it can go to the ear. So in normal ears, you have that vibration hitting both ears equally. But then in conductive hearing loss, as I mentioned before, the air conduction is kind of impaired. So the bone conduction sort of takes over. So that's why in the impaired conductive, the ear with conductive hearing loss, you have more bone conduction than you have air conduction. So the bone conduction is better. So that's why you hear conductive in the Weber's test is better on the bad ear. Okay, so sorry, here. So say this is the bad ear, the red ear. So you can hear that better here. And then sensory neural, it's louder in the good ear, because sensory neural, so whether the sound gets to the cochlea via air or bone conduction, the cochlea is at fault, so the cochlea cannot pick it up. So that's why it's better in the good ear, because this ear is faulty and you won't get much. Does that explanation make sense, or does anyone need a clarification? Okay, good. But do you mention if you need a clarification on that? Okay, so now the Rinne test, which is the other one. So as you can imagine here, so say you do the Weber test, and then someone tells you that, oh, okay, my right ear is louder than my left ear. You can't really, you won't really know which ear is the bad ear, because in conductive hearing loss, so it's louder in the bad ear, but in sensory neural hearing loss, it's louder in the good ear. So you won't really know until you identify whether it's conductive or sensory neural hearing loss. Now the Rinne test. So it's a tuning fork again. So you hit the tuning fork, and then so they place it on the mastoid process of the temporal bone, which is just behind your ear, and they place it there, and then they also place it in front of your ear. So you can imagine if it's on the mastoid process, the sound will travel via bone, and if you have it in front of the ear, it will travel via air. So now you're testing whether air conduction or bone conduction is better. So usually, as we said, air conduction is louder because you have the ossicles, it's going to amplify the sound, so that's louder. But in conductive hearing loss, you'll have more bone conduction than air conduction. So sound is heard louder via bone conduction, so when the tuning fork is placed on your mastoid, rather than when it's next to your ear, so via air. So you call that Rinne Test negative. But in sensory neural hearing loss, say you can still hear a little bit, but it's just a hearing impairment, then it will be like usual. It'll just be so the way that air is still better than bone, basically. But you still won't hear as well as a normal ear. But air will still be better than bone. That's why it's Rinne Test positive. So yeah. Okay, now we'll go through a bit about audiometry, so how to interpret audiograms. So yeah, I do understand that this might look a bit scary, but it's honestly very, very simple to grasp. So you have the x-axis and you have the y-axis. The y-axis is so the intensity of the sound. So as we said, the decibels. So really loud sound will be 100 decibels. So I know it's kind of flipped, but and not a lot of sound will be more towards here. So quiet sound will be up here. And then this up here is the frequency of the sound. So high frequency, so that's like high pitch frequency, and here it's like low pitch frequency. So what happens and how do you do audiometry, and how do you record an audiogram? So what happens is the patient is asked to respond when they hear a sound. So different types of sound are given to the patient, so are presented to the patient. So sometimes there might be loud sound, sometimes they might be quiet sound. So say someone someone might hear a sound that's really loud up here, but then they won't really hear, they might not hear a sound that's say like 10 decibels, for example. And then sometimes they might hear a sound that's at 10 decibels up here, but they might not hear it at that loudness or that quietness at a different frequency. So audiometry kind of tells you like the limit to or the extent of their hearing. And what's also important to know is that the sound is presented in each ear via air, but also via bone. So so one part of it is when the sound is on their mastoid, and one part of it is when it's like just normal air. So then that kind of gives you an idea of bone conduction and also air conduction. And usually what it should look like is here. So the picture on the right, this is a normal audiogram. And as you can see, there's lines close together, and so you do it on both ears. Right is usually a circle and it's red, and left is usually presented as a cross, and if it's in color, it's blue. But this is normal. But here, so you can tell that this is a left ear. But also when they did air and bone, there was a gap. So here this is the air conduction, and this is the bone conduction. So you can tell that the bone conduction, when the sound was placed on their mastoid, that they could hear sounds better through bone conduction than via air conduction. So that tells you that there's a discrepancy there. So their bone conduction is better than air conduction, which is not normal. So that's why they have a conductive hearing loss. So now with audiometry, you know that this person has a conductive hearing loss, and this is in the left ear because there's an X. Another way to know what ear this is in, if you only have the bone line, is this, so if you imagine this kind of bracket as an ear, and you imagine like a person, so if you're looking at them, that would be the patient's left ear. So that's another way to tell which ear it is. But yeah, so that's how you interpret audiograms. But we'll go through some to test your knowledge in a bit, so it'll become clearer. So yeah, so this is just a diagram I showed you before, and it just explains it better. So if you need to go over it, this is a really good diagram. So yeah, so for example, just to reiterate, when there's normal hearing, you can hear quiet sounds at all frequencies, but if there's profound hearing loss, you won't be able to hear like those loud sounds. And then really quickly about tympanograms, because you probably don't really need to know much, you don't need to know anything about tympanograms, I don't think, but just to know that they're also used. So this is like a normal tympanogram. What happens is a vibration is put through the air, it hits the tympanic membrane, and then it vibrates back. And then you see, you kind of measure the reflected vibration. So this is normal, but say there's otitis media with effusion, we'll go through what that means, but basically there's like liquid in the middle ear, so the tympanic membrane won't vibrate very well, so that's why it's kind of flat. The sound isn't really reflected very well. And then negative here, because there's a eustachian tube defect. As remember, there's a eustachian tube here, and that's to equalize the pressure in the middle ear. So it joins to the nasopharynx, so pressure can be relieved. Because if you think about it, there's nowhere for air to go. So that's why this is kind of like a ventilator system almost. So if there's a dysfunction there, then there's going to be problems there. And that's why the tympanic membrane might not vibrate so well. But yeah, that's a tympanogram. So causes of hearing loss. So we'll go through causes of hearing loss, but we'll try and make this interactive with cases. So if you've done ENT before, then hopefully you'll know the answers. Otherwise, we'll go through it anyway, so don't worry. So yeah, this is the first question. Okay. Okay. Oh yeah, we don't need a poll for this slide, but okay, so a 37-year-old lawyer, he comes to you, you're the doctor, and he presents with progressive hearing loss. He says it's difficult to hear people, especially in crowded areas. During his social history, you find out that he enjoys golfing and target shooting in his free time. What do you think this is? Yeah, just type it in the chat. But yeah, does anyone else have any ideas? Yeah, perfect. Well done, guys. So yeah, it is noise-induced hearing loss. Yeah, so noise-induced sensory neural hearing loss. That's perfect. Well done. So yeah, so this is caused when there is trauma to the ear, because there is like intense sound. So this can either be like one-time exposure to really, really, really loud sounds, or it can be continuous exposure to not so loud sounds, but that still causes damage over time. So the louder the sound, the shorter amount of time it takes for noise-induced hearing loss to happen. And what happens is there's damage to the hair cells. So we remember in the cochlea, there's the hair cells. And if there's a lot of noise, then there's going to be damage to them. And this is irreversible, not progressive. So it's irreversible, but it won't be progressive. It won't get worse if you wear ear protection and prevent further exposure to loud sounds. And treatment for this is just ear protection. That's all. But if it's really affecting the quality of life, then you could also have hearing aids. But usually, you just use ear protection to prevent further degeneration or further hearing loss. Okay, so that question, so we have a poll here. It is, so I want you to apply what you've learned about audiograms and think, we've kind of just gone through the mechanism of sensory neural so noise-induced hearing loss. So I'll launch a poll and you can vote and think and see which one you think it is. So I'll give you a minute or two. Okay, great. Most of you have voted, so I'm going to end the poll now. Okay. So most of you have voted for C and D, but the actual answer is actually A. So it was a tricky question, so we'll go through why that is. So firstly, we'll go through D. So D is really similar to what I explained before. So you have the bone conduction line here, and the brackets are a bit different to what was on the other slide, but this is the bone conduction line, and this is the air conduction line. So here you can see that there's a discrepancy between air conduction and between bone conduction. So this is actually conductive hearing loss. So it's not this. So how do you know which is air and which is bone? So the air line will usually always be X's or O's. The bone line will have brackets. So this can either be the square brackets, or here, strangely, it has like brackets like this. So that's a bone line. So this is you have an air bone gap here. So that's why you know it's conductive hearing loss, because there's a discrepancy between air and bone conduction. And then the next common answer that people said was this, and you are very, very close. I don't want to reveal too much because this is an answer to one of the other cases, but we'll go through why it's not this in a moment. And B as well, it won't be this. But if you look at B, perhaps you got confused with A because it's sort of flipped a little bit. B is characteristic of a certain disease. So the answer is actually A. So it's A because in noise-induced hearing loss, you have like a loud noise, and it actually affects, you have like a characteristic dip at 4 kilohertz. So the frequency at 4 kilohertz, you have that little dip there. So that's characteristic of noise-induced hearing loss, and you're correct that it's because it's sensory neural hearing loss. That's why the bone and air conduction, the two lines are close together, so they don't properly show the bone conduction line, but you've got both the right ear and the left ear drawn here, and there's no air bone gap discrepancy. So that's why you know that it's sensory neural hearing loss, and you know this is noise-induced hearing loss because it's got a characteristic dip at 4 kilohertz. So I hope that's clear. Okay, so so next question. So what do you think this could be? Okay, so a 2-year-old child is presenting with fever and ear pain. His mum is concerned with his hearing and says that he is not as alert or responsive to her words. She's concerned about his hearing and delayed speech. His notes show that he has had 2 other episodes of this before. So what do you think it is? Yeah, perfect. So you guys are correct. It's otitis media with effusion. So yeah, otitis media with effusion, also known as glue ear. It's really common in children, and especially peaks around like 2 to 3 years of age. And it's caused by, there's loads of different causes, but it can be caused by infectious causes. So bacteria is like one of the most common, and some organisms are strep pneumoniae, Haemophilus influenza, Moraxella catarrhalis, and you also have viral causes, so rhinovirus, RSV, and the virus that causes influenza as well. I think it's also Myxoviridae. But yeah, so can anyone identify what's common with most of these pathogens? Do you kind of see a link between these pathogens at all? Okay, no. So the link is that they're all pathogens that cause respiratory infections. And the reason is we mentioned that the eustachian tube connects the middle ear to the nasopharynx. So these pathogens, if they have so as I mentioned, this 2-year-old child presents with fever and ear pain. So that's quite like upper respiratory tract symptoms. So those pathogens can travel up the eustachian tube into the middle ear, and they can cause otitis media with effusion. And then another cause is eustachian tube dysfunction. So not this child, but other children can have eustachian tube dysfunctions. And when there's like poorly ventilated middle ears, because that eustachian tube has a problem, there can be a vacuum. So it's not inflammatory like the others, it's not infectious, but there can be a vacuum, and you can have liquid there as well, which is the glue ear. And there's also anatomical abnormalities, so you can have like cleft palate and craniofacial abnormalities, which can cause that too. Treatment depends on the cause. For example, if it's bacterial, you'll have oral amoxicillin. Let's say it's the viral cause, that's not going to do anything, so you wouldn't do that. But you can also, depending on it, so say if it's viral, you can also watch and wait and see what happens in the child. And if it's recurrent and it's kind of chronic, you can also do morongotomy. I don't think I'm pronouncing it right, but it's basically where you make an incision in the tympanic membrane, and it equalizes the pressure in both the middle ear, because if there's something wrong with the eustachian tube. And there's also a grommet, which is like a little tube inserted into the tympanic membrane, and that equalizes the pressure if there's a deformity with the eustachian tube, and it can't do that. Okay, next one. Okay, so question, which audiogram is this? Okay, you can answer now. Which audiogram is this? There's a poll up. Okay, I'm going to end the poll now and share the results. And yeah, most of you were correct. The majority of you were correct. It is D, because if you think about it, if there's an effusion in the middle ear, that's the sound cannot be conducted to the cochlea. So that's why you have conductive hearing loss. And that's why it's this. And as I mentioned before, I explained this is conductive hearing loss because there's a air bone gap. And it's not B. We're still awaiting for the disease that causes B, but yeah, we'll clarify why it's not this in a moment. Okay, next one. Okay, So next case, a 72-year-old woman comes into the clinic with her daughter. She is really frustrated because she's finding it difficult to hear out of both ears. The daughter says that her mum has started to watch TV at really high volumes, and the volumes are so high that even the neighbours have complained, but the mum does not think that it's that high. Yes, that's correct. Well done, guys. It's presbycusis. Also, Aksa, I think, sorry if I pronounced your name wrong. You said, sorry, what was the answer for the last one? My internet stopped working. Was that otitis media with effusion? I think that was. And the one before that was noise-induced hearing loss. But yeah, so this one is presbycusis. And presbycusis, you have degeneration of the cochlea. It's kind of similar to noise-induced hearing loss, but this happens with old age. It's not really loud noise, but okay, I'll answer your question in a minute. But so it's not really loud noise, but you have noise, so it's not exactly due to old age, but it's because as you grow older, you've been exposed to more noise and then more environmental noise toxicity over the years, and this kind of builds up, and that causes degeneration of the cochlea. So there's loads of different ways it can happen. So it can either be due to loss of hair cells. So this is called sensory presbycusis. You guys, if you're in medical school, you won't really need to know this, but just extra interest. So if there's loss of the ganglion cells, so where that transduction happens into the action potential, that'll be neural presbycusis. And there's also metabolic, which is to do with like the electrolyte imbalance and stuff like that, and like the endolymph and perilymph, and that's striatal atrophy. It is seen in old age, which we've said, and higher frequencies are affected the most. Usually lower frequencies can be heard, and sometimes there's that characteristic. Sometimes if people like raise their voice and they're trying to explain to the person with presbycusis and what they're trying to say, and they're talking in a really loud voice, the person might say, "Don't shout, I'm not deaf," to a really loud voice, and that's because they can probably hear the low frequency voice, and they can hear that clearly, but they won't be able to hear the high frequency. And so what can really help is a high frequency hearing aid, and that can be really effective. Okay, so now we will do another question. So which audiogram is this? Okay, go for it. Okay, perfect. That was 30 seconds, and most of you have answered. So yeah, so well done. It was C. This is presbycusis. So higher frequencies are affected, lower frequencies are usually okay, and there's no airborne bone gap, and there is no airborne gap, so you know it's not conductive hearing loss. So well done. And two of you picked B. So this is the last one. So it's the disease that's coming up. So now we've reached this, and we'll explain why it's like that. Okay. So what do you think this could be? So we know it's that audiogram that people are getting confused with, and it's got that characteristic audiogram. But what disease is this? A 32-year-old pregnant woman. She presents with bilateral hearing loss and ringing in the ear. After questioning, you identified that there is a family history of similar problems. So what do you think it is? Yeah, well done, that's correct. So it's otosclerosis. So yeah, we mentioned it in the first question as well, but what exactly is it? So otosclerosis is usually a hereditary disorder, and that's why the family history was very important. There's bony deposits that occur within the stapes footplate, so here, and the cochlea, and as the first question is kind of indicated, it can spread to the oval window as well. It's more common in females and becomes worse during pregnancy, perhaps due to like the hormones, and hearing loss may be mixed. So you have a bit of sensory neural and conductive, and that's because this bit is the conducting area, but it's also affecting the cochlea. So that's why the hearing loss may be mixed. And also there is tinnitus, and dizziness is also experienced. And treatment for this is surgery, so you'll fix the ossicles, and also hearing aids as well can help. Yeah, so that's a bit about otosclerosis, and I won't do a poll because it's the last one that's left. So you know, with the process of elimination, it's this audiogram here, and so this is the characteristic audiogram. So you might not be able to sort of infer from what we talked about so far, but when you see this bit here, so it kind of, these two lines, the bone line and the air line, they touch, and that's called a Carhart notch right there. So when you see a Carhart notch, you know it's otosclerosis. So that's just very characteristic of this disease. But yeah, that's what you'd see. Oh, and I think Aksa, you said your internet cut, to just to explain. So yes, which was the audiogram for otitis media with effusion. So this was the audiogram for otitis media with effusion. So that's conductive hearing loss, so that's why it's there. Okay, so last case, no more audiograms, but last case, a 26-year-old man went scuba diving, and he now presents to you with ringing in his right ear, and he says he feels dizzy all the time. He also states that it is hard to hear people with his right ear. After questioning, he mentions whilst he was scuba diving, he experienced ear pain in his right ear, but this had dulled over time. What do you think it could be? Okay, that's good. Anyone else with any suggestions? Okay, perfect. We have TM rupture and swimming ears. Swimming ears, I think you might, so there's one that's called otitis externa. It's got a name for it. I can't remember the name exactly, but I think it's called like surface ears or something like that. And that's what swimming ears, but I think that you're getting confused with otitis externa. But if you said swimming ears because of scuba diving, it's not exactly what this case is right here. So what this is so as Aksa said, it's tympanic membrane rupture or perforated eardrum. So it usually arises from trauma. So this can be barotrauma to do with pressure, which happened here, or acoustic trauma if there's a really, really loud noise, and it can perforate the eardrum. Or it can be caused by chronic middle ear diseases that make the tympanic membrane quite vulnerable, or like a foreign body. And a perforated eardrum can make it vulnerable to infections because you don't really have that barrier anymore. And then a cholesteatoma as well, which is kind of like an ear cyst near the tympanic membrane. So symptoms, you'll get ear pain, mucus-like pus-filled or bloody discharge from the ear, hearing loss, and also ringing, tinnitus. So does anyone know why exactly tinnitus happens? Does anyone know like sort of like the physiology of tinnitus, like the pathology of tinnitus? So if you're typing that, I'll come back to it at the end and I'll answer that question. But if anyone has any suggestions, do put it in the chat. It's quite interesting. You also have spinning sensation, which is vertigo, nausea or vomiting, and then treatment is usually heals within a few weeks without treatment, but sometimes you can have a patch or surgical repair. So you can use a patch or surgical repair, yeah. Okay, so I'll answer that question about tinnitus in a minute, but let's do this question. I think this is the last question. So, okay. Yeah, so now this is in the right tympanic membrane rupture. So what do you think is correct? I'll give you a couple of minutes to answer, or a couple of seconds. Okay, it's nearly been a minute. Last few seconds if anyone else wants to answer. You know, this question requires a bit of thinking. Okay, I'm going to end the poll now and share the results. Okay, so the majority of you said C, which is really good because yes, the answer is C, but we'll go through, but there was a lot of mixed responses. So we'll go through why it is C. Okay. Oops. Okay. So when you think about a tympanic membrane rupture, what is that? Is that conductive or sensory neural hearing loss? Conductive, yes, correct. So it's conductive hearing loss. So we'll go through it via that. So because we learned about Weber first, we'll see which one is better. So like we said, in conductive hearing loss, that bone conduction is a lot better than air conduction in that ear. So that's why the bone conduction is better in the bad ear with the conductive hearing loss compared to the good ear, assuming that the good ear is normal. So because you have conductive hearing loss, the Weber's test, when that vibration from the tuning fork will go to so you'll hear it via the bad ear first, so, and because this is right tympanic membrane rupture, that's why you know that right will be louder than left, because this is the Weber's test is sort of testing conductive hearing loss, and in that bad ear you don't have air conduction, so that bone conduction sounds so much louder. So that's why it won't be the first two answers, because that's suggesting left is better than right, but actually right will be better than left. And it won't be equal either, right will be better than left. So we're assuming that the other ear is normal. So and now we do Rinne's test. So we've got Rinne's test positive, or is it Rinne's test negative? So Rinne's test positive is when that air conduction is better and is louder, and that's what usually happens, or it can happen in sensory neural hearing loss. But actually, if you've got conductive hearing loss, that bone, as we've mentioned multiple times, that bone conduction is better than that air conduction. So that's why it'll be Rinne's test negative, because it'll be louder when the tuning fork is placed on the mastoid compared to when the tuning fork is right in front of the ear. So that's why the answer is C. If you have any questions or require further clarification, please do post in the chat. So yeah, just about tinnitus, what I've asked before. Yeah, so tinnitus is when there's ringing in the ear, so you're hearing like sounds that ringing, but there's no ringing there's no external stimuli that's causing the ringing, but you're hearing ringing in your ears. And yeah, that was a really good suggestion from AXA. So not sure, but I think it's something to do with the inner hair cells being impaired. So yeah, that's exactly right. So because in some conditions where there is hearing loss, there's impairment, especially when there's like sensory neural hearing loss, but sometimes in conductive as well, there's impairment with that. So the hair cells, that they move, or they create action potentials that aren't actually there. So that's why you get that tinnitus. So from some other examples, so you have conductive hearing loss, you can have stuff like wax or foreign body impairing that conduction. You might have suppuration where there's lots of like pus there. We've gone through that. You can have ossicular problems, so something to do with the ossicles. And then for sensorineural, you can have like congenital causes. You can have end organs, so similar to how presbycusis is. There's also other end organ causes, such as occupational acoustic trauma, and like drugs that can eventually like build up and cause ototoxicity. That's why some drugs are called like ototoxic, because they can degenerate that like cochlea and so forth. And there's also Meniere's disease. You guys might have heard of it. Not in the scope of this lecture, but it's more to do with balance, so the vestibule. But it can affect hearing as well, because the cochlea is right next to the vestibule, so obviously it could be affected. And then there's also nerve lesions. So this is to do with the vestibular cochlear nerve. So there's loads of causes of that. There's also, for example, meningitis. It causes a really distinct audiogram, which I haven't included here, but it's quite interesting if you wanted to have a Google. But yeah, so it is actually over 8, but there's not much left. So if you do want to keep watching, please do, but it won't take too long. So really quickly, nice guidelines to hearing loss management. So someone comes to you with suspected hearing loss. First you see, are they a child or an adult? And that way you have different treatment pathways. So if it's an adult, it depends on the symptoms and everything, but you have tailored healthcare services for each person. There's assessment and referral. Perhaps if it's earwax, you remove the earwax. You can do investigations with an MRI if needed. Assessment in audiology services, management in audiology services and secondary care, and then follow-up in audiology services. So you can kind of see that it's kind of a very multidisciplinary sort of approach. So you start with like primary care, and you go into secondary care, and there's also like audiologists involved, and so many different professions involved. And then if it's a child, it'll be quite similar, but also Nice Guidelines says has extra on the surgical management of otitis media with effusion in children. And it basically kind of depends on what the cause is. So if it's like a congenital cause, or if it's like a craniofacial defect, you're going to fix that. Or do you need like grommets inserted? And there's a lot to take into consideration. So that's why like there's different pathways on that. But as we said before, it's important to consider the patient holistically. And then you can also have implantable devices. We kind of mentioned cochlear implants, and they have specific criteria. So not everyone can get a cochlear implant, but usually it's like if you're a child and if they're bilaterally, prelingually, and they have a hearing impairment, then usually they're given that. Or sometimes if it's an adult and they have other disabilities as well, other sensory disabilities, and they rely on their hearing, they might be considered for a cochlear implant as well. But yeah, I just put this pathway in. You don't need to know the specific details, obviously in medical school, but just know that there's a lot involved when making decisions. Okay, the final bit, ENT devices and technology. So there's loads of different things that you can use for hearing loss, but there's with the advances in technology, there's advances in the ENT speciality as well, and these are a couple of things that you can use. So you don't need to know this in much detail, but it's good to kind of be aware of it just for interest. So you've got hearing aids, as you're all probably aware of, but there's different types of hearing aids. There's like open fit or closed fit models. So this one goes right into the ear, but this one goes behind the ear. And then you also have more types of hearing aids as well, but they're usually for mild, moderate, and severe hearing loss. You also have cochlear implants. So you, as we mentioned before, you have a cochlear implant, and I won't go through the mechanics of that because we don't have enough time for that. But there's also a bone-anchored hearing aid. So this is also called as Barhers. And as you can see here, the pinna and the auricle here, they're kind of quite important to hold that hearing aid in place, but sometimes you might have things like this, for example. So this is called microtia, which is basically when there's an abnormality in your pinna, so your pinna or auricle doesn't form properly, so you can't hold that, so that you're unable to hold that hearing aid in place. So that's why you have BAHA, so they're bone anchored hearing aids here. So, and then you've also got middle ear implants as well. So this is usually to moderate to severe, and this is when hearing aids don't work. So it's like another alternative. And there's also ossiculopathy. So if there's a problem with the ossicles, then you can use surgery to repair that. And also a bit about robotic surgery. It's advancing in many specialities, even in ENT. So this is called the Da Vinci machine, and it can be used as well for many ENT surgeries. But yeah, just a little bit about that. So just some takeaway messages. Thanks for sticking with me so long. So some important points. So hearing loss and impairments can have massive impacts on the individual and society. So not just with this, but like every disease or condition that you come across, they can have such a massive impact on individuals and their quality of life. So it's really important to take that into consideration. And there are many causes of hearing loss. So as we went through this, so many different causes. And it's also important to know the difference between conductive versus sensory neural hearing loss as well. And that's really important for the treatment. And screening tests and audiograms can tell you a lot. So Weber's and Rinne's, they're screening tests. They're just to kind of identify quickly in the clinic, but audiograms can tell you, they're further investigations, and they can tell you so much. But also, just as all of you have identified, with just the history, you can tell a lot as well. So all aspects of the investigation and presentation and the things that you do are very important. And management varies. So as always, treat the patient holistically and think about what they would want and what's in their best interests. Okay. And also ENT is fun. I hope you enjoyed this a little tutorial, and if you have any questions, please put it in the question and answer or in the chat below. And please do fill in the feedback form. It takes less than a minute, and it'll be really useful to see where I can improve or what bits that you liked. But yeah, I hope you liked that. And any thoughts and extra suggestions, do put it in the chat. And I think we have 2 questionnaire and answers, so I'm just going to quickly check that. I'll stop sharing first. Okay. Does both, so Sapphire has asked, does both air and bone conduction occur normally, but in air pathway blockage, there is blockage, only bone conduction occurs? Yeah, that's correct. So air and bone conduction usually both occur, but air is what's mostly used because, you know, you have that amplification of sound with the ossicles, and that's why the ossicles are there, to amplify the sound. But if that air conduction doesn't happen, then you're only relying on bone conduction, and that's why that's sort of amplified a little bit. Where does the infection travel to from the ear? So it travels to the middle ears. So it maybe get a diagram up. So I've stopped sharing now, sorry, but yeah, so you've got a eustachian tube, and it travels from the nasopharynx into the middle ear where the ossicles are there. So yeah, so those were the questions. Please do fill in the feedback form. Yeah, thank you very much for attending.